So this is a quick video on the clinical anatomy of vas deferens. You also call it as ductus deferens. And what is the main function of this vas deferens? So it starts from the testis, okay? It is at the back of, it collects the semen and it transports it through the process, okay? And it helps in ejaculation, carrying the sperm or semen. But why it is clinically important? The clinical importance is that the ductus deferens can be cut like tubectomy. Okay, so the procedure is called vasectomy and it is a technique for male sterilization. So what is that? It's a technique for male sterilization. So the process is simple. On both the sides, the cut ends are ligated and kept away from each other so that the semen cannot be transported. But problem with the vasectomy is the sterility by vasectomy is not immediate because it requires at least 12 to 16 weeks. That means almost the sperm production takes 3 months of time, right? So it is stored for 3 months. So whatever which is left over can be pumped out even after the tubectomy. So the stored sperm can be in the reproductive, the sperms are stored in the reproductive tract for up to 3 months. Okay, so that's the reason sterility is not immediate. It requires at least 30 ejaculations to become aspermic. Okay, and clinically there should be at least 2 semen analysis reports which are showing no sperm. Then only you can declare a man as sterile after vasectomy. Vasectomy in comparison to tubectomy, it's a easy and a painlessly performed procedure under local anesthesia. Okay, we give bilateral scrotal incisions or through a single midline scrotal incision, and the ends are brought out, they're cut, they're ligated, and they're repositioned back either in the facial interposition or you have to turn them back on themselves so that there is no recanalization, because spontaneous recanalization can lead to restoration of the fertility. And also the post-surgery complication is patients might have, in 5% of the cases, there is a chronic testicular pain. So to decrease all these side effects, post-operative pain, and also the suturing and all, there is a new technique called no scalpel technique, also called as keyhole vasectomy. Okay, what do we do here? With the help of a forceps, we catch hold of the vas deferens and we make a small puncture hole in it. Okay, when you make a hole on the skin, you can after making the skin, the vas deferens pops out. We have to suture it, we have to cut it and suture it, then it can be repositioned back. So there is no suture, there is no need of a scalpel. Okay, and this procedure is safe, and also it has less complication rate, less pain, easy recovery. Okay, so this is a no scalpel technique. So what is your take home when it comes to vas deferens clinical anatomy? We do vasectomy, but immediately after male sterilization, the male is not sterile. It takes around 3 to 4 months. Okay, and also there is a new technique called the no scalpel technique, also called as keyhole vasectomy. So this video covers the clinical anatomy points of uterine tubes. The other name is fallopian tubes. What is the major function of these fallopian tubes? They help in carrying, they capture the released ovum from the ovary immediately after the capture. They help in transport of this ovum so that the fertilization of both the ovum and sperm can occur inside the fallopian tube. So this is its major function. But if there is any infection or inflammation of the uterine tube, we call it as salpingitis. Okay, and this salpingitis, acute or chronic salpingitis, is one of the cause for infertility. So of late, because there are high cases of infertility, one of the cause is the development of salpingitis. So most common cause is always along with the salpingitis, the tubal blockage. Okay, in chronic cases there will be stricture formation or blockage of this fallopian tube, and we have some tests clinically available to look at the patency of these uterine tubes. So we call them as tubal patency tests, and there are two things that require special mention. One is a Rubin's test. We also call it as an insufflation test. The other is a radiographic method called as hysterosalpingography, wherein we inject a radio contrast dye. And let's come back to the Rubin's test. What do we do in this Rubin's test? We push some air into the uterus with the help of a Rubin's cannula, and this will flow through the uterine tubes through the fundus. They enter into the uterine tubes or fallopian tubes, and a gush of air comes out into the peritoneum. And you have to auscultate over the iliac fossa on both the sides, and if you can feel the gush of air, the sound of air, hissing or bubbling sound of the air, or when you are auscultating over the iliac fossa, it is clear that that part or that side of the tube is patent. So this is how we perform this insufflation test or Rubin's test. When it comes to hysterosalpingography, it's a radiological technique, and it helps you in visualizing the uterus cavity and also the lumina of the tubes with the help of a radio opaque dye. Okay. So this beaded appearance what you see here is due to tubercular salpingitis or TB salpingitis will give a beaded appearance or tobacco pouch appearance. So we're done with the tubal patency test and salpingitis, and we all know that one of the common sites for ectopic pregnancy is the fallopian tube. The fallopian tube being a tube of a tiny diameter, so the growth, the blastocyst penetration into the fallopian tube leads to the rupture of the tube, leading to high complications. Okay, so the complications are high when there is a tubal ectopic pregnancy. Because of the rupture of the tube, there will be peritonitis and all. So it's a life-threatening stuff. So we're done with the three important stuffs. The fourth very important thing is tubectomy. So why do we do tubectomy in clinical practice? To produce female sterilization. So like vasectomy, tubectomy is the female sterilization procedure. So it is very important. It's a commonly done procedure, and let us show some respect to it and learn it in detail. So these are the methods which I have just mentioned. One is laparoscopic coagulation method. So laparoscopic techniques are trending. In laparoscopic techniques, there are two things. We can use bipolar or monopolar cautery, and we can sterilize the fallopian tube. If this is the tube, you can sterilize it and it will heal and it will form strictures and all. One more procedure which is commonly practiced is through the laparoscopy, you can either clip it or you can pass a band. Okay, tubal ligation by either clip or ring. These are the two commonly done procedures. Of late, there are some obsolete procedures which are not done nowadays, but let's learn one point each from each technique. Let's start with fimbriectomy. What do we do in fimbriectomy? The fimbria has a role in capturing the ovum and sending it inside. If you do fimbriectomy, what happens? The fimbria is removed so that there won't be any catching of the ovum. Similarly, we have Irving's procedure. Okay, Irving procedure, what we do simply is you have to cut the ends. Okay, so we have to remove these parts, but after cutting, the open ends of the proximal ends of the uterine tube are inserted back into the wall of the uterus. So you have to turn them to the back side and you have to stitch it to the back of the uterus. Okay, so this is Irving's technique. We're done with these four. Next is Pomeroy's technique. Of late, it's commonly done procedure. Okay, in Pomeroy's technique, we loop the uterine tube. We loop it like this, and so after looping it, we suture it and we cut the ends, and the ends are cauterized again so that they won't fuse back. So this is Pomeroy's technique. Next is Uchida technique. It's an obsolete technique, and in this there is a proximal stump and there is a distal stump, and in between we remove 4 to 5 centimeters of the stump. So the proximal stump is pushed back into the meso-ovarium or mesosalpinx. Okay, it goes into the meso-ovarium. The distal stump is sutured here. So this is Uchida technique. The last technique is Pritchard or Parkland technique. It's simple. We ligate the ends and we just remove a segment here. It's a simple one. So this won't be pushed back into the mesosalpinx. So only a tiny segment of 1 to 2 centimeter is removed here. So these are the different techniques for uterine tube ligations or female sterilization method, that is tubectomy. So this will conclude our discussion on clinical anatomy of the uterine tubes. So urinary bladder is a part of urogenital system, and we'll be discussing only the clinical important points, clinical anatomy, which is in the syllabus when it comes to the urinary bladder. First thing is, we have two kinds of bladders here, named bladders. One is trabeculated bladder and the other is hourglass bladder or hourglass shaped bladder, like this. Okay, trabeculated means trabeculations are present inside inner surface of the bladder. In any case of chronic obstruction to the outflow of urine, that is most of the times because of the benign prostatic hyperplasia, and we all know the lower part of the bladder has a prostatic covering. Okay, when there is a BPH, there will be a chronic obstruction to the outflow of the urine, and this causes hypertrophy of the bladder, and this hypertrophy leads to trabeculations in the bladder, and we call it as a trabeculated bladder. This is first thing. Next is hourglass bladder. This is a developmental defect wherein there is a constriction in the mid part of the bladder. Actually, bladder is a single hollow cavity, but in the middle, if there is a constriction due to the development, then you will see this hourglass bladder. This is simple and easy. But third very important condition is ectopia vesicae. The other name is bladder exostrophy. This is also a developmental defect. Okay, and the reason for ectopia vesicae is, just make a note of it, it is failure of mesoderm to migrate into the lower abdominal wall. So try to remember the single word. What is this? It is failure of mesoderm layer to migrate into the lower abdominal wall, that too between the umbilicus and the genital tubercle. So because there is no mesoderm here, okay, the ectoderm and the endoderm, ectoderm is the skin of the abdominal wall, endoderm is at the back of it, we have a bladder. Okay, bladder is covered by endoderm. So the ectoderm and endoderm, they are unsupported and they are very thin. So because of the lack of the mesodermal support, this may rupture, and rupture leads to the exposure of the cavity of the urinary bladder to the outside. Okay, so what is ectopia vesicae? Due to improper mesoderm, failure of migration of the mesoderm, the cavity of the bladder is exposed on the surface of the body. So this is an important condition, developmental defect. Next is suprapubic cystotomy. Cystotomy means it's a procedure. So when you want to collect a sterile urine, and also in cases where there is obstruction, acute urinary retention cases, usually we resort to Foley's catheterization. Sometimes because of the blockage, the Foley's cannot be done and there is a severe acute retention symptoms. In that scenario, we do this suprapubic cystotomy. And what happens in this procedure called suprapubic cystotomy? The bladder is distended with about 300 ml of fluid, and this leads to the anterior aspect of the bladder comes direct contact with the anterior abdominal wall. So you can directly enter into the bladder without entering into the peritoneal cavity. So this is operation called suprapubic cystotomy. We also have cystoscopy, wherein we observe the interior of the urinary bladder with the help of an endoscope. So done. But fifth very important thing is, whenever we discuss urinary bladder, the most important clinical condition seen in injurious cases is urinary incontinence. So what happens in this condition? Before that, you need to understand the nerve supply of urinary bladder. And in the nerve supply of urinary bladder, you have somatic nerve, that is which is a voluntary, and we have visceral or involuntary supply. Involuntary supply is by parasympathetic nervous system and sympathetic. So we call it as an autonomous nervous system. So we have both parasympathetic and sympathetic nerve supply. The three important structures when it comes to urinary bladder in our system are the detrusor muscle, which is a part of the body of the urinary bladder, and we also have an internal urethral sphincter and external urethral sphincter. The external urethral sphincter is supplied by the pudendal nerve, okay, which takes origin from S2, S3 and S4. What is the importance of this pudendal nerve? It's a somatic nerve. It has a voluntary control. It supplies external urethral sphincter. So this gives you a voluntary control. So yes, there is a bladder distension and you have a sense of urination, but you won't be doing it in social places, and the control is with the help of pudendal nerve. And if there is any damage to the pudendal nerve, this leads to urinary dribbling and urinary incontinence. And next thing is, we also have but the parasympathetic supply, which is parasympathetic means craniosacral outflow. So the sacral part is S2, S3 and S4. There is a vesical plexus, and this supplies both detrusor muscle and internal urethral sphincter. So whenever there is an activation of the parasympathetic system, it leads to contraction of the detrusor and relaxation of the internal, and this helps in urination. Okay, so activation of the parasympathetic system leads to urination, and this parasympathetic system responds by a cholinergic. Okay, so what if I give an anticholinergic medication? The major side effect of an anticholinergic medication is urinary retention, or okay, so urinary retention. So why in anticholinergic? When you give that, this system won't be working. So detrusor muscle is relaxed and internal urethral sphincter is contracted, so urine retains there. Okay, so this is the first clinical point, that is anticholinergic medication causes urinary retention and it acts on the parasympathetic nervous system. So how does sympathetic system act? Sympathetic system T11 to L2, and we do have a hypogastric and vesical plexus, and sympathetic has relaxation of detrusor and contraction of the internal. So it's similar to anticholinergic part. So it helps in storage of urine. Okay, it helps in storage of urine. So after this knowledge, let me tell you one thing. There are two important clinical conditions here. One is urinary incontinence, are two types, maybe because of automatic reflex bladder or autonomous bladder. We'll discuss with the first part, automatic reflex bladder. What happens in a spinal shock whenever if there is a sudden damage, to the spine, okay, in acute injury to the cervical or thoracic segments of the spinal cord, there will be a spinal shock. And in this case, as first the muscle of the bladder is relaxed, and first immediate response is the muscle of the bladder is relaxed and there is contraction of the internal urethral sphincter. So immediately there is a urinary retention. But after few days, what happens? There will be a spontaneous contraction, reflex contraction of the bladder. As the patient recovers from spinal shock, you will see reflex contractions. Okay, and these reflex contractions occur after the complete filling of the bladder every 2 to 4 hours. So suddenly after 4 hours, the patient urinates. So this is known as automatic reflex bladder. And this is seen in cases after the recovery of a spinal shock. So this is first condition. It's a kind of normal urination pattern. But And when does it occur? It occurs whenever there is a thoracic or cervical segmental damage leading to spinal side. But if there is a damage to the sacral segments of the spinal cord in the lower parts, this results in autonomous bladder. In this, what happens? The brunt of attack falls on this part. The detrusor muscle relaxes. Okay, its capacity is greatly increased. It fills, and it overflows. So there is a continuous dribbling in this condition. So you will see a continuous dribbling of urine, and you will see an involuntary passage of urine for every 3 to 4 hours here. Involuntary passage in 3 to 4 hours. So this is the classic difference when it comes to urinary incontinence. So let us discuss the anatomy of kidney in detail. So we do have a separate video on the development of kidney and the developmental or congenital anomalies. So in this video, I'll be covering the gross anatomy of the kidney and also the relations of the kidney, both right and left kidney. And I'll also detail you about the arterial supply to the kidney and what are the vascular segments in detail. And we'll also see the microscopic anatomy of the kidney, that is the structure of the nephron and what is juxtaglomerular apparatus. Okay, and we'll conclude the session by understanding some of the important applied aspects of anatomy of the kidney. So let us begin now. So when it comes to the kidney, each kidney, it's a bean-shaped organ. It has a upper pole and lower pole. We all know that. And it has a medial border and a lateral border. It has an anterior surface and a posterior surface. The two poles of the kidney, the upper pole is in broad, whereas the lower pole is a bit pointed. Okay, and the upper pole, the broadness is because of the presence of the suprarenal gland, also known as adrenal gland. So adrenal gland is located on the upper pole. So the two surfaces, among the two surfaces, the posterior surface is a bit flat, whereas the anterior surface is irregular. And the borders are simple. We all know the lateral border is convex, but the medial border is concave, and this contains hilus or hilum. A depressed middle part of the medial border is hilum. And in the hilum, we have three important structures from anterior end to the posterior end. So we have a renal vein, a renal artery, and a renal pelvis. So these are the three structures in anterior to posterior direction. And the same thing when it comes to the location of the kidney. What we have is very important. They are present on the posterior aspect near to the vertebrae and ribs, and they are retroperitoneal organs. So they are not covered by the peritoneum completely. Okay, so they lie outside the peritoneal cavity. That's the reason they are retroperitoneal organs. Only the anterior part has a peritoneum. The posterior part is free, flat, smooth, and they occupy the following areas, like the epigastric. Starting from the epigastric area, they cover a hypochondriac area, lumbar area, umbilical region, everything. And they extend from, the extensions are important because when you are doing a surgery and when you are trying to do open surgeries on the kidney, you have to expose the kidney, right? So we have a 12th rib here. Okay, this is the 11th rib, this is the 10th rib, and we have T10 vertebral segment. They vertically extend from the upper border of the 12th thoracic rib to the L3 part. Okay, we have L3, upper part of 12th rib to the L3, and we should know that the right kidney is slightly lower than to the left kidney. So this is the right kidney and this is the left kidney, and this is the upper border of the 12th rib. That is what I am talking about. From here it extends to L3. Right kidney is slightly lower than left, and left kidney is slightly medial. Okay, it is close to the center than the right kidney. And when you look at the long axis of the kidney, it is directed downwards and laterally like this. So it goes downwards and it is laterally. That means the upper poles are like, if this is the left kidney, so the right kidney is slightly lower, and left kidney is more close to the median plane, and it is the median plane is this direction. The long axis of the kidney is downwards and laterally. So this will conclude our discussion on the location of the kidney and also the gross anatomical features. So the same thing is depicted here. The outside structures are done. Internally, this is what you need to know. As I already told you, we have a vein, we have an artery, and then posteriorly we have a renal pelvis, wherein the renal ureter enters and it divides into the major calyces and minor calyces. So these are the major calyces, which again subdivided into minor calyces. When you look at the substance of the kidney, it is made up of millions of nephrons, which are structural and functional units. So we'll be discussing them, but the kidney is covered by the capsule. Okay, and beneath the capsule we have a cortex and medullary differentiation. We have renal medulla and renal cortex, and between the medullary spaces we have renal sinuses. We have renal sinuses. So this will conclude the internal structure part. So now let's jump into the relations of the kidney. So as you can see from this image, we have both the right and the left kidney. Because right side there are some different organs, and on the left side we have some different organs. Okay, so this diagram has, this is the left side and this will be the right side. On left side we all know that the spleen plays a major role. On both the sides we have a suprarenal gland. So suprarenal gland will be covering this. So duodenum is present more on the right side. Okay, the jejunum plays a role on the left side, and we also have a pancreatic area, and we have a colic area, jejunal area, and the hepatic area. So don't confuse with this diagram. The details are mentioned in here. So let's discuss first the relations which are common to both the kidneys. Then we'll go into the relations of the right kidney and also the relations of the left kidney. So as I already told you, the upper pole of each kidney is related to suprarenal gland. Okay, and the lower pole is about 2.5 centimeter above the iliac crest. The medial border of each kidney, we all know, is related a bit to the suprarenal gland and also the ureter. That's it. So above the hilus we have suprarenal gland, below the hilus we have a ureter. That's it. So the posterior relations are common again for both. Okay, so these are the posterior relations. The posterior surface of both kidneys are related to the following structures like, yes, the diaphragm, the medial and lateral arcuate ligaments, psoas major muscle, the quadratus lumborum, transverse abdominis muscle, subcostal vessels, and also the subcostal iliohypogastric and ilioinguinal nerves. Okay. In addition, the right kidney is related to the 12th rib. Okay, and the left kidney is related both to the 11th and 12th rib. Because right kidney is being a bit lower, it is only related to the one rib, that is the 12th rib. So that's it. Posterior relations are common to both. But when it comes to anterior, the abdominal cavity has different organs on the right side and different organs on the left side. Simple. On the right side we have a right suprarenal gland, we have liver on the right side, the major part, and second part of duodenum is close to the right side. The hepatic flexure is on the right side, and small intestines loaded. Okay, small intestines will be present. And next, when it comes to the anterior relations, the left side we have a left suprarenal gland, we have a spleen, stomach is on the left side, the pancreatic tip is on the left side, splenic vessels, the splenic flexure and descending colon are on the left side, the jejunum occupies the left side of the body. So this simple. So these are overall the relations are same when it comes to upper pole, medial border and all. But posterior are also same, except right kidney is related to the only 12th rib, left is 11th and 12th rib. But anteriorly, because there are different organs on the right side of the body and left side of the body, try to remember the organs on the right side and also on the left side. So this gives you a clarity. And try drawing the same image which I just told you. Okay. So this will conclude our discussion on the relations of the kidney. Very important. And next is the arterial supply. There are some vascular segments in the kidney. Okay. In each kidney there are 5 vascular segments. See. This is the kidney, this is anterior side, and we have a posterior side, we have an apex, and we have a bottom, we call it as a lower pole. Okay, lower segment, apical segment, and anterior is again divided into upper segment and middle segment. Okay, and a bit lower, which is broad, and we have an apical segment. So each segment of a kidney is supplied by a segmental artery. So this differentiation is based on a segmental artery. But the basic blood supply of the kidney comes from renal artery, which is arising from the abdominal aorta. So renal artery, it divides into anterior and posterior divisions at or near the hilus. So when it enters the substance of the kidney, it branches further, dividing into segmental arteries, and each segmental artery supplies a segment. So we have 5 segments as such. So with this basic knowledge, let us see how it divides. And starting with the renal artery, as I told you, it has anterior and posterior divisions, then it becomes a segmental artery. And from here, from the segments, there are some lobes. So there is a lobar artery, and each lobar artery is divided into an interlobar artery. See, this is the interlobar artery. Once it enters at the terminal point near the cortex, it passing the medullary pyramids here, and in the cortex it gets divided into arcuate arteries, and these arcuate arteries, they further gives rise to interlobular arteries. So these interlobular arteries, they become the afferent arterioles or afferent glomerular arteriole. So we have an afferent glomerular arteriole which forms glomerulus, and from which you will see afferent glomerular arteriole coming out. So this becomes vasa recta, and now this gives rise to interlobular veins, arcuate veins. Okay, then comes interlobar veins, it is lobar veins, and then it becomes a renal vein. So this is how the process runs. But most important thing is each segment, be it be an apex, be it be a posterior segment, anterior segments, middle or lower segments, they are all supplied by a single artery, that is the segmental artery, which divides and forms an arcuate-like structure, an interlobular artery, which further gives rise to the afferent arteriole. So this is how the vascular system in the kidney is arranged. So the next part of the discussion will be on the microscopic anatomy of the kidney. We all know the structural and functional unit of a kidney is nephron, right? And when you want to know the parts of the nephron, you know this afferent arteriole, which is giving rise to afferent. So this part of the discussion is done. But this arteries, they form a network, and we call it as a glomerulus. And glomerulus is inside a capsular-like structure called Bowman's capsule. Okay, so these two things, what is that? The arteriolar network from afferent and efferent arterioles, that is the glomerulus, along with a Bowman's capsule. We call these two as a renal corpuscle or Malpighian corpuscle. What is this? Renal or Malpighian corpuscle. So what does it do? It helps in filtration of the urine. Like urine forms because of the ultrafiltrate of the blood here. Once there is a filtration, there is a big structure called a tubular structure called renal tubule, which is convoluted in the proximal part and distal part. That's the reason these two are known as proximal convoluted tubule and distal convoluted tubule. But after the proximal convoluted tubule, there is a loop-like structure. We call it as a loop of Henle, and there is a descending limb of loop of Henle. There is a major turn. Then there is an ascending limb of loop of Henle, and the distal convoluted tubule terminates into the collecting tubule. Okay, so the collecting tubule or collecting duct of Bellini or collecting duct. So this is how the urine flows, and the major function of these renal tubules is they help in reabsorption and also secretion. So some elements, important elements which are required for the body are reabsorbed. Let's take an example of glucose. Almost the entire glucose is reabsorbed from the proximal convoluted tubule, but there are some substances which are also secreted. We call it as a tubular secretion. And the final endpoint is collecting tubule. Along with this, there is one more important structure called GJ apparatus. We also call it as juxtaglomerular apparatus. So this juxtaglomerular apparatus consists of three important structures. One is a macula densa. Okay, macula densa. Number two is GJ cells. Okay, juxtaglomerular cells. And number three is some granular cells in between the macula densa and glomerular spur. What is macula densa then? If this is the glomerular structure, okay, this is the glomerulus, and we have proximal and distal. So the distal convoluted tubule cells, which are in close proximity to the glomerulus, they are modified into the macula densa. Okay, then comes the juxtaglomerular cells. In between the glomerulus, we have juxtaglomerular cells. And also along with this, the macula densa and glomerulus, we have some aglanular cells. So what is the function of this juxtaglomerular apparatus? So these GJ cells are juxtaglomerular cells. They secrete renin. We all know that there is a system called RAS system, renin angiotensin aldosterone system, which helps in long-term regulation of the blood pressure of the body, and this is taken care by the renin, which is the initial hormone which is synthesized by the kidney. So you know what juxtaglomerular cells does. Next is macula densa. This macula densa has a sodium sensing potential, so it helps in regulating the fluid and also the sodium levels in the body. So we are done with the microscopic anatomy of the nephron also. Let us quickly jump back to the clinical anatomy aspects of the kidney. So when you want to expose the kidney, as you know that it lies at the level of the 11th and 12th rib, and in the close proximity we also have a pleural cavity. So sometimes you might injure and you might lead to iatrogenic pneumothorax, okay, pneumothorax, which might lead to tension pneumothorax and death of the patient. So while you are exposing the kidney, we should be pretty careful about the borders, okay, because there is a danger of opening of pleural cavity. And next is a renal angle. What is a renal angle? Renal angle is the angle between the lower border of 12th rib, what you can see here. So it's an angle between lower border of the 12th rib and also the outer border of erector spinae muscle. So lower border and outer border of erector spinae muscle. This is the renal angle. And when you palpate here, okay, if you elicit tenderness by applying pressure over this angle, you can identify a pyelonephritis or infection of the kidney. If something is wrong with the kidney, you can elicit tenderness in this renal angle. And next is, we all know the pyelonephritis or infection of the kidney is pyelonephritis. It requires IV antibiotic therapy and all, and it is very important to differentiate UTI from pyelonephritis, because pyelonephritis should be treated promptly by hospital admission. But when there is an infection to one part of the kidney, the right side, it never goes back to the left side, because the kidney is covered by the renal fascia and this has a midline attachment. So from infection cannot pass from one kidney to the other side of the kidney. Okay, and next is renal stones. The stones are common in the kidney along with gallstones. The one more common surgical complication is the renal stones. And there are various kinds of renal stones. We have calcium renal stones, calcium triphosphate. We call it as a staghorn colliculus. We got uric acid stones. We also have cystine stones. Okay, so there are various kinds of renal stones. But what is more important is there are latest surgeries for the management of the renal stones. Among them, the most important one is extracorporeal shockwave lithotripsy, wherein we use, it's a non-invasive method, and we use a shockwaves like ultrasound shockwaves, which are outside the body generated and they are focused onto the stones. And as you can see, if there are bigger stones, they are lysed and they are passed in the urine. Okay, it's a non-invasive procedure instead of doing an open surgery for retrieval of the stones. And there are some more diseases, let us say tuberculosis of the kidney. Okay, it's also a common condition. And even renal transplantation of late is very important. Okay, so and if there is any kidney disease, the common manifestations will be periorbital edema, pedal edema, hypertension. Okay, and in chronic kidney diseases there is anemia, because kidney is the site of production of erythropoietin. Okay, if there is any damage to the kidney, there will be anemia associated with chronic kidney disease. So this will conclude our detailed discussion on clinical anatomy of the kidney, the microscopic anatomy of the kidney, the arrangement of arteries. So what are the vascular segments of the kidney, what are the relations common to both the kidneys, and also the difference in anterior relationship of the kidney. And this is the diagram for that. And we also had an analysis on the gross anatomy of the kidney. So there are only two important and high yield topics from the topic perineum, which is in the syllabus. Okay, when we discuss perineum, so we will be focusing on two topics. One is ischiorectal fossa, very important topic, and the other is we have pouches or spaces, that is deep perineal pouch and also superficial perineal pouch. So these two are important. Okay, we'll be discussing these two stuffs along with their anatomy, boundaries, contents, and also their clinical aspects. But before going into that, you should know what is perineum. Perineum is the lowest part of the trunk. Okay, and when it comes to males, the perineum contains two openings. One is for gastrointestinal system, that is anus, and the other for common for both urinary and genital system. Okay, but in females there are three separate openings in females. Okay, because in females urinary system has a separate opening, genital has a separate opening, that is vagina, and also the gastrointestinal anus is a separate opening. So perineum has three openings in females and two openings in males, and we all know what is perineum is. Okay, it's the lowermost region at the lower end of the trunk in between two thighs. But the same perineum is divided again with the help of a transverse line. Okay, so which joins, let me draw it here. We have the pubic symphysis here. So this is the pubic symphysis. These are the ischiopubic rami, and we have an ischial tuberosity here. These are ischiopubic rami, and we have ischial tuberosity here, and this is pubic symphysis. And at the bottom we have coccyx or coccygeal, or along with that the ischial tuberosity and coccyx are linked together by the sacrotuberous ligament. So this part is perineum. So these are the boundaries of the perineum. And now a line joining these two ischial tuberosities will divide the perineum into an anterior region and a kind of posterior region. Okay. So these two triangular areas are known as, the anterior one is the urogenital triangle and the posterior one is anal triangle or anal region. So there are two regions, urogenital region and anal region. So the space, clinically important space in anal triangle or anal region surrounding the anus is ischiorectal fossa. Whereas clinically important spaces in urogenital region is the superficial and deep perineal pouches. So we'll be discussing these two pertaining to these two regions. So that's the reason I gave you an introduction to the perineum. So let us quickly jump into what is ischiorectal fossa. As I already told you, it's a space, that is, it's a wedge shaped space. It's not a triangle, it's a wedge shaped space which is situated on either side of the anal canal. So this is rectum and here is the anal canal. On either side of the anal canal you can clearly see the ischiorectal fossa, which is a wedge shaped structure. See this? It has a wedge shaped structure. So both the sides we have it. And when I say wedge shaped, it has an apex, it has a base, it has both anterior and posterior surfaces, and it has medial and lateral wall. See this? This is the lateral wall and this is the medial wall. So let us look at the boundaries. You all know that the ischiorectal fossa is present in the anal triangle, the posterior part of the perineum. And it's a wedge shaped space. It is present on either side of the anal canal and it is present below the pelvic diaphragm. And its its size is it's 5 centimeter in length, 2.5 centimeter in width, and also 5 centimeter in depth. It's not important, but more important is the boundaries. The base, what you see here, it is formed by the skin. Okay, and when you look at the apex is a point where you can clearly see this muscle which covers this area is obturator internus, and it is covered by a fascia, that is the obturator fascia. So this obturator fascia is meeting an area called, see this, it's meeting this muscle is levator ani. Okay, and this meeting point of levator ani and the obturator fascia is the apex. So base is done, which is skin, apex is done. So let's look at the medial wall. So this area is the medial wall. So medial wall on top is formed by levator ani, the upper part, and in the lower part you can see the external anal sphincter covering the anus. Okay, so the external anal sphincter muscles form the lower part of the medial wall. Let us look at the lateral wall. Lateral wall, as I already told you, we have obturator internus along with its fascia, that is obturator fascia, and we also have ischial tuberosity. So these are the ischial tuberosities. You can see it's extending to here. So lowermost part is ischial tuberosity. Anterior and posterior are not seen in this diagram. Okay, we need a separate diagram for this. Not important, but let me try this. We have an ischiopubic rami in the front, okay, and we have sacrum at the back. Okay, this is the sacrum and this is the ischiopubic rami. Extending from here, we have different kinds of membranes, perineal membrane. We also have different muscles here, and we have urogenital diaphragm here like this. Okay, so this is the area. But what we are looking at now, we are looking at the anterior and the posterior. Anteriorly, it is bounded by this part, this is perineal membrane, and posteriorly it is bounded by a sacrotuberous ligament. So near the sacrum we have a sacrotuberous ligament, and near the what we call ischiopubic rami we have a perineal membrane. So these are the two things, anteriorly and posteriorly. So we're done with the boundaries, very important. With the help of this diagram, it is easy. And anterior is perineal membrane and posterior is sacrotuberous ligament. So why this fossa, these two fossa are important? You can clearly see they are surrounding the anal canal and the rectum. Okay, they're cushion-like. They contain fat strands in them. They contain fat strands. So this fossa, it allows distension of both the rectum and anal canal during the passage of the feces. So this is very important. Next is, there are a few more things. You know, the boundaries, it's not enough. There are some recesses. Okay, we have both anterior recess in the front, posterior recess in the back, and there is also a horseshoe shaped recess which connects. See, if these are two ischiorectal fossa, they are connected from the back by a horseshoe shaped recess. So what is the significance of this recess? Infection from one ischiorectal fossa can spread to the other ischiorectal fossa with the help of the horseshoe recess, which is present posteriorly. So we have anterior recess, posterior recess, and a horseshoe recess. So these recesses are extensions of, what we call it as, these are the extensions of ischiorectal fossa. So the ischiorectal fossa is extending beyond its boundaries to form recesses. So same kind of recesses are also seen in fourth ventricle of the brain, which we'll be discussing very soon. And now you have spaces. You have spaces and also the contents of the ischiorectal fossa. Now first we look at the spaces of ischiorectal fossa. Let me draw a small diagram for this. We all know that it's the anal canal, okay, and surrounding the anal canal we have the external anal sphincter here, and we have levator ani muscle here. the same diagram, I'm drawing it in a rough manner, and we have obturator internus and the pubic bone with pubic tubercle at the side, and this is Hilton's line or white line, which is white line of Hilton, which is a differentiating factor for anal canal. From here we have perianal fascia extending till pudendal canal. See, I haven't told you this, but it is very important. There is a facial canal in the lateral wall of the ischiorectal fossa. This is the ischiorectal fossa. And on the lateral side, we have a facial canal called Alcock's canal or pudendal canal. And this canal contains pudendal nerves and also internal pudendal vessels. So try to remember this. On the lateral wall of the ischiorectal fossa, we have a canal called Alcock's canal or pudendal canal. And this contains pudendal nerves and internal pudendal vessels. Very important. But there is a fascia called perianal fascia, which is extending from the white line of Hilton from the anal canal to the Alcock's canal or pudendal canal. So this line is perianal fascia, and this differentiates the ischiorectal fossa into two spaces. One is perianal space and the other is the main ischiorectal space what we are discussing. Okay, so ischiorectal fossa has two spaces. One is perianal space, which is superficial, and the other is ischiorectal space. What do you make out of these two spaces? When it comes to perianal space, both these spaces contains fat strands. Okay, but in perianal space, the fat is very tightly arranged with small locules. Okay, very tightly arranged fat with small locules. So because of this tight arrangement, what happens, if there is any infection in the perianal space, there is no space for the abscesses to expand. So there is tightness. So this tightness irritates the surrounding nerves, leading to an excruciating pain. So infections in the perianal space are very painful due to the tension caused by the swelling. Go back to the other space, that is the ischiorectal space, which is large, which is deep, and the fat here is loosely arranged. Okay, and there is no complete septation. Here you will see septa separating the fat, but there is no complete septation, so that there is minimal tension when there is an infection, and the infections in the ischiorectal space are least painful. So if I ask you one question, how does the ischiorectal fossa is divided? It is divided into two spaces. One is superficial and other is deep. The superficial is anal space, perianal space, and the deeper space is ischiorectal space. In which space, if there is an infection, it is highly painful. It is perianal space because of high tension generated. So these are the two spaces. So when it comes to contents part, you all know that it has a pudendal canal which contains pudendal nerves and internal pudendal vessels. Along with that, there is a fat, as I already told you. It's not a new stuff, but what is new is this canal. This ischiorectal fossa also contains inferior rectal nerves and vessels. Inferior rectal nerves and vessels, because it is in proximity to the inferior part of the rectum. Similarly, in males and females, there is a scrotal and labial nerves and vessels which pass through this ischiorectal fossa. So these are the contents of the ischiorectal fossa. So what we are done with? We are done with the boundaries. You know the recesses briefly, in detail the spaces and the contents. So now let's add the clinical anatomy or clinical pearls. So why are we interested in ischiorectal fossa? The importance is there is a condition called anorectal abscesses. Okay, most of the patients in general surgery practice, they come with a pain near the anorectal region because of the development of the abscesses. So these abscesses may form either sinuses, or if not treated properly, they might form fistulae. When it comes to anorectal abscesses, yes, they have a painful throbbing swelling in the anal region, and there is a pyrexia, okay, which is called swinging pyrexia. Whenever there is an increased pus, there is pyrexia. But they are divided accordingly into perianal abscesses around the anal cavity, and ischiorectal abscesses, if they occur in the ischiorectal fossa, if they occur in the perianal region, we call it as a perianal abscesses. Similarly, there are some submucous and pelvirectal abscesses which are very rare. But when I say ischiorectal abscess, okay, so these perianal abscesses are painful, but ischiorectal abscesses are painless. So ischiorectal abscesses are treated, not properly treated because they occur very deep. But problem with ischiorectal type of abscesses is they form an anal fistula. Okay, so we call it as an ischiorectal type of fistula. Let me draw the diagram for ischiorectal type of anal fistula. So this is, yes, it's an anal canal again, and we have anal crypts in the anal canal, and on the side of it we have an external anal sphincter. As we all know, we have a pubic bone with internal obturator fascia and obturator internus with the pubic bone. Okay, and we have both a superficial anal space and a deep space. Now you see, I'm drawing most of the sinuses or fistula, they open into anal crypts from the ischiorectal fossa. Okay, and this is the abscess, and it has two openings. See, one it opens into the anus, other it opens to the outside onto the skin. So this is the ischiorectal type of anal fistula. This is one case. Other is the perianal abscesses, they form, and most of the time these perianal abscesses are bilateral because, as I already told you, this space has a horseshoe shaped recess which can spread bilaterally, both the ischiorectal and perianal abscesses. And the third important thing is just focus on the same diagram. Okay, let me take back to the other diagram which is clear. See, they offer cushion-like support around the anus here, right? They're offering cushion-like support. In malnutrition and in severe diarrhea, post-diarrhea, and in cachexic conditions, due to the loss of fat in the ischiorectal fossa, due to the loss of fat here, the patient might develop prolapse of the rectum. Okay, you might see prolapse of the rectum due to the loss of fat. What we call the loss of fat because of malnutrition or diarrhea or cancer cachexia. So it's loss of fat in the ischiorectal fossa. And last, might not be an important one, it's an ischiorectal hernia which occurs from hiatus of Scalbe. Let me show you the hiatus of Scalbe here. As I already told you, the apex of the ischiorectal fossa is formed by two things. One is obturator internus, which is covered by obturator fascia, and the other is levator ani. Sometimes there is an opening here. There is an occasional gap between the tendinous origin of the levator ani and the obturator fascia, and we call it as hiatus of Scalbe. So what are we calling it? We are calling it as hiatus of Scalbe. Try to remember this. Why it is important? Through this space, the pelvic organs may herniate. Okay, and we call this condition as a ischiorectal hernia. It's a different kind of hernia. So that's it. These are the most important what we call the clinical anatomy points of ischiorectal fossa. Okay, so what we are done with the boundaries, the anatomy, and very important, the clinical anatomy of ischiorectal fossa. This fossa is limited to the posterior part, that is the anal region. Let's jump back to the anterior one, that is the urogenital region. Okay, and here we have two important spaces. So what are these two important spaces? We have superficial and deep perineal spaces, or we can also call them as the pouches. So let's look at these structures in detail. So here is the urinary bladder. Okay, in the back we had seen anal cavity, but in the front we have a urinary bladder, and we have a prostate which is covering. Levator ani is present throughout, and this is the apex, and yes, this is the obturator internus at the side. And now we have two spaces here, and we have a urogenital diaphragm which is separating the topmost part, and on the bottom what we have is Colles fascia. So this is Colles fascia. The same thing is depicted here. We have two fascia of urogenital diaphragm. One is on the top and the other is on the bottom. So we have superior fascia of the urogenital diaphragm, superior fascia, and we have an inferior fascia. In between both the superior and inferior fascia of the urogenital diaphragm, we have a deep perineal space or pouch. Okay, I'll tell you the boundaries, I'll tell you the contents of it. Similarly, beneath the inferior fascia of the diaphragm and also the Colles fascia. This is the superficial fascia. The most superficial is the Colles fascia. So between we have another space called superficial perineal space. So this is deep and this is superficial perineal space. Let me repeat it. Between the Colles fascia and inferior fascia of urogenital diaphragm, here we have superficial perineal space. And between the inferior fascia and superior fascia of urogenital diaphragm, we have a deep perineal space. Okay, done. You know where these spaces are located. Let us look at their boundaries and contents. We'll start with the superficial perineal space or pouch. Okay. As I already told you, most superficial is Colles fascia, most deep is the perineal membrane. Okay. So the perineal membrane is the superficial fascia of what we call the urogenital, this one, what we had seen here, the urogenital diaphragm. And on each side we have ischiopubic rami on the sides. As I already shown you, we have an ischiopubic rami here. You can clearly see ischiopubic rami. And anteriorly we have the spaces are continuous with the spaces of the scrotum, penis and anterior abdominal wall, the structures of the anterior abdominal wall. But posteriorly they won't have much space because it is closed by the fusion of the perineal membrane and Colles fascia. Okay, so these are the boundaries for the superficial perineal space. Logic is simple. As I told you, we have a Colles fascia like this. This is the genital opening. Okay, this is the genital part. We have a Colles fascia here and we have a perineal membrane here. They are fusing together posteriorly, limiting the space. Anteriorly, it is continuous with the spaces of the scrotum, penis and anterior abdominal one, but posteriorly closed by the fusion of the perineal membrane. Deeper, we have perineal, superficial, we have Colles. On each side, we have a ischiopubic rami. So what are the contents of the superficial perineal pouch? Contents are different in males and females. When it comes to males, most superficial is the root of the penis. But in females, the most superficial is the body of clitoris. And in males, we don't have any glandular structure. We only have ducts. So this contains the ducts of bulbourethral glands. But they are well developed and we call them as greater vestibular glands, also known as Bartholin's glands in females. So in females we have Bartholin's glands and their ducts. But muscles are common to both. There are some nerves and arteries, but I don't think remembering too many is not easy, and even I forget those stuff, so I'm not mentioning it. But when I say contents of the superficial pouch, at least remember this, because from only these stuff they're asking even MCQs in PG entrances also. So you know the male and female contents of the superficial perineal pouch. The next thing is what are the common for both male and male are muscles. So what are the muscles seen in superficial perineal pouch? Make a note of it: ischio-cavernous muscle, bulbospongiosus muscle, and superficial transverse perineum. So with this background knowledge on superficial perineal spaces, let's quickly jump into the deep perineal space or pouch. So what does deep perineal pouch contains? It contains, let me finish off the boundaries, then we'll go to the contents. Superficial, we all know, we have a Colles fascia, we have a perineal membrane, then we have a deep fascia of the urogenital diaphragm. Superficial is the perineal membrane, deep is the superior fascia of the urogenital diaphragm, and on each side we anyway have an ischiopubic rami which is continuing. Anteriorly there is a closure, it's not open anteriorly, both anterior and closed posteriorly. The deep perineal space is closed by the fusion of the perineal membrane and urogenital diaphragm. So this is the closure of the fascia. So both anterior and posteriorly it is closed, and we have a deep perineal space here. Okay, so what are the contents of this deep perineal space? In males, it contains a part of urethra and bulbourethral glands. The ducts are present in the superficial space. The glands are present in the deep. There is no glands. So both Bartholin glands and its ducts are most superficial. But the female, it has a part of urethra and vagina. But what are the muscles? Very important. Sphincter urethrae and deep transverse peroneae. Okay, sphincter urethrae and deep transverse peroneae are the muscles which are common with deep peroneal space. So we're done with the anatomy. Just try to look at this image and try to remember this chart which I have given. It's more than enough. Let's quickly jump into the simple point, the clinical significance. There are not much clinical significance. Yes, there are abscesses, perineal abscesses might form. Okay, if there is any trauma to the urinary bladder, it might go to the superficial pouch and it can even reach to the umbilicus in the anterior abdominal wall, because the anterior part is free and it is in continuum with the penis, scrotum, labium and all. So that's the reason in pelvic trauma you will see an edema, a fluid filled condition in all these structures. That is one clinical point. The other is the Bartholin's glands, which is more important. As I already told you, the Bartholin glands are specific to females and they are present in the superficial perineal pouch of the urogenital triangle. This is easy now because you know the anatomy well. But what do? They secrete mucus-like fluid. Okay, and when you examine them, normally the Bartholin glands are not detected on physical examination, but only when they become blocked, they swell to form fluid-filled cyst. Okay, so they become infected and inflamed, and we call this condition as Bartholinitis. And the most common cause of infection is from Staphylococcus or E. coli. So this is what you need to know about the Bartholin's gland says. So this will conclude our discussion on the perineum, and we try to cover two important things. The one is the ischiorectal fossa and the other is the deep peroneal or superficial peroneal pouches. So we are discussing about pelvic diaphragm. So there are two important diaphragms for exam point of view. One is the pelvic diaphragm and the other is thoraco-abdominal diaphragm or the usual diaphragm, what we refer to, which helps in respiration. So what is the function of this pelvic diaphragm? It offers support to the pelvic organs, okay, because it is the lowermost part of the abdomen and it offers supports to the pelvic organs. And how it offers support? With the help of two important muscles. Okay, we have, as you can see here, so this muscle which is extending to the ischial part of the bone from the coccyx. Okay, so ischium of the pelvis from the coccyx, we call it as ischio-coccygeus muscle. So one thing. Next we have yes, from the coccyx it is extending to the ilium part of the pelvic bone, so we call it as iliococcygeus muscle. And we also have another muscle which is extending to the pubic bone from the coccyx, and we call it as pubococcygeus. So these three muscles together are known as levator ani muscles, and the major component of a pelvic diaphragm is levator ani muscle. So what are the muscles? Starting from ischio-coccygeus, we have iliococcygeus and pubococcygeus muscles. And this is what, there is another muscle which is situated behind the levator ani, okay, which is not seen in the image. We just call it as a coccygeus muscle. Okay, it only attaches the sacrum and coccyx part, more or less the vertebral part. Okay, so the pelvic diaphragm is composed of muscle fibers of both levator ani and coccygeus, but the major contribution is by the levator ani. So from whatever image we have seen, we are now sure that there is both right and left levator ani, and they lie almost horizontally in the floor of the pelvis, and they are separated by a gap, and through which you can easily see the transmission of the urethra, vagina and rectum. So this is the female part what we are looking at. You can see the urethra here, and this is the vagina and the rectum. So they are lie on both the sides. So it consists of three parts: pubococcygeus, iliococcygeus or ischio-coccygeus, also known as pubio-rectalis muscle. And the pubococcygeus, which is the main part of the elevator, okay, the main damage during the childbirth occurs to this pubococcygeus. Okay, main damage occurs to the pubococcygeus. And most of the time the ileococcygeus, the most posterior part of the levator ani, is often poorly developed. And the puborectalis muscle, okay, it has an anorectal junction. It forms what we call it as a muscular sling kind structure, okay, and sometimes it is considered, see, this is a muscular sling like structure around the part. And so what are the functions of the pelvic diaphragm per se? The pelvic diaphragm, it is very important in providing support for the pelvic viscera. Okay, it is important in providing support for pelvic viscera like bladder, intestine and uterus. And the major function of pelvic diaphragm is it maintains continence because it is surrounding the urinary and anal sphincters. And at the time of birth, it facilitates the birth by not allowing or resisting the descent of the presenting part, so that there will be a rotation of the fetus through that it comes out to the pelvic girdle. And it also helps to maintain an optimal intra-abdominal pressure. By somehow, if there is any damage to these pelvic diaphragm, this leads to the prolapse. Okay, the prolapse, rectal prolapse, or the uterine prolapse in females, prolapse of the uterus. Okay, so these are the important stuff you need to know about the pelvic diaphragm. The supports of the uterus we'll be discussing when we do the uterus part, because pelvic diaphragm is one part of the supports of the uterus. And next we have the intra abdominal, or what we call is as thoraco-abdominal diaphragm. You focus here, we have now openings in this. We are looking at from beneath part, from the lower part of the abdomen. Okay, the diaphragm you are seeing is the lower part, and you can see there are some major openings in the diaphragm. So they are asking in the exam, list out the opening seen in the diaphragm. So there is a foramen for inferior vena cava. So here is the inferior vena cava, and just adjacent to it you can see a right phrenic nerve. So this is the right part, this is the left part, and there is also an opening for esophagus. Okay, we call it as an esophageal hiatus, there which you will see opening of esophagus, anterior and posterior vagal trunks. And left to it we have a left phrenic nerve, yes, and beneath this we have another opening which is bound by median arcuate ligament. So through this opening you can see, we also call it as a aortic hiatus, and there is the abdominal aorta and thoracic duct are coming out of it. So just focus on these three important structures here. One is esophageal hiatus, aortic hiatus, and also IVC foramen or foramen of inferior. These are the three openings which are present, major openings. There are minor openings also. But one more important thing you need to remember here is, there are what we call it as a crus of the diaphragm. We have left crus and the right crus of the diaphragm. So we'll be seeing those details in the next slide. So focus on the openings here. So what is diaphragm? Diaphragm or thoracoabdominal diaphragm is a curved musculofibrous dome shaped sheet, and it separates thoracic from the abdominal cavity, and it is convex. The upper surface is convex, it faces the thorax, and the inferior surface or lower surface is convex, what we have just seen, and it is directed towards the abdomen. And what is the chief important function of the diaphragm? It is supplied by the phrenic nerve and it helps in respiration. It's a chief muscle of respiration. And the different parts, as I told you, there is a crus of the diaphragm. So what is the crus? There are two crus, right and left crus. Right is longer, left is shorter. So it's a musculo-tendinous bundle. It is attached to the anterior surface of the vertebral column. Okay, and from where it is taking origin? It is taking origin from the anterior surface of the lumbar vertebrae L1, L2 and L3. Okay, and from there, from the vertebral part, it goes and it attaches to the central tendon. Okay, and when these two fuse together, they form median arcuate ligament. You have seen it. Here is the median arcuate ligament, and this is the right and the left crus. They are taking origin from the vertebrae and they are going and getting attached to the central tendon, and here is the median arcuate ligament. So there is a diaphragm has a coastal part also, because the costal part is the one which is the vertebral part is the crus of the diaphragm. The costal part, it takes origin from the lower 6 ribs and also the xiphoid process of the sternum, and even that also gets inserted into the central tendon. So from the ribs it is coming, from vertebrae it is going, and they are all forming a central tendon of the diaphragm. What is that? The central tendon of the diaphragm is a point of convergence of all the peripherally located muscles which are forming the diaphragm. So what is the arterial supply, venous drainage and innervation? Innervation we already discussed. It is phrenic nerve. So damage to the phrenic nerve causes phrenic nerve palsy or diaphragmatic palsy, in which the movement of the diaphragm is reciprocal to the opposite healthy side. So the phrenic nerve is derived from C3 and C5, similar to another nerve called, what we call it as, there is a shoulder referred pain. So even the supraclavicular nerve, okay, supraclavicular nerve and also the phrenic nerve has a common innervation. So that is the reason if there is any phrenic nerve or diaphragmatic irritation, the patient will complain of a shoulder tip pain. Okay, in cholecystitis and pancreatitis, in gallstones and all, if somehow the right side dome of the diaphragm is irritated by intra-abdominal pathology, and from the left side if there is a splenic rupture, we call it as a Kerr sign, irritation of the diaphragm leading to the left shoulder tip pain. So this is a kind of a clinical anatomy point when it comes to the innervation. So just remember phrenic nerve, rest are all not important. The venous drainage is simple, phrenic veins, superior and inferior phrenic veins. Arterial supply is simple, superior and inferior phrenic arteries, which are the branches of the thoracic aorta. Just remember these two important, and also the phrenic nerve part. So we're done with the vasculature and the parts of the diaphragm with the diagram. As I told you, the structures which are piercing the diaphragm is an important part to be discussed. There are 3 openings: caval hiatus, esophageal hiatus and aortic hiatus. Levels are important. Okay, inferior vena cava. Vena cava has 8 letters, right? So vena cava has 8 letters. So that's the reason it is at T8. So at T8 we have vena cava. Esophagus has 10 letters. Esophagus. Okay, or esophageal. Esophageal has 6 plus 10. So it is at T10 level. Along with the esophagus, it transmits vagus nerve. Along with the IVC, it transmits right phrenic nerve. What are the structures? So aortic hiatus, you see, aortic 6, hiatus 6. So 6 plus 6, 12. So we have a T12 here, and the structures which are present piercing through the aortic hiatus are the aorta, the thoracic duct and azygous vein. So that's it. These are the structures which are passing through the diaphragmatic hiatus or openings. So the applied anatomy is important here in the diaphragm. So what is a hiccup? Hiccup or hiccup is due to a spasmodic contraction of the diaphragm. Okay, so it can be because of irritation to the diaphragm, or also it's phrenic nerve, or there is a hiccup center in the medulla. If it gets irritated, even then the patient will develop hiccup. And what is the most important clinical condition with which the patient will present with refractory hiccups which doesn't respond or which are continuous, are uremic encephalopathy or uremia. Okay, any alteration in the blood urea levels, they lead to hiccups. And we have a referred pain. We already discussed the both phrenic nerve and suprascapular nerve, they have a common origin. So what is that origin? C3, C4, C5. So that's the reason any diaphragmatic irritation produces a shoulder tip pain. But let's focus more on diaphragmatic hernia. Okay, herniation of the abdominal contents through the diaphragm into the thorax is diaphragmatic hernia. So when you look at the diaphragm structure here, there are some weaker areas in this. So one is through this area, the other is through the central tendon, or some is to the posterior lateral parts. So from these, there might be a herniation. Let us look at these parts. So how this herniation occurs. So before detailing you, when I say diaphragmatic hernia, we have 2 things here. One is central hernia and the other is one is congenital hernia and the other is acquired hernia. The acquired hernia we also called as hiatal hernia. it's because of the acquired cause. It can be due to traumatic causes also, but hiatal hernia is the common one. When I say congenital hernia, we have four varieties here. The most important or the most common one is posterolateral hernia. What is that? Posterolateral hernia is more common. What is the other name for posterolateral diaphragmatic hernia? It is also known as Bojdalet hernia. Bojdalet, because it opens from the foramen of Bojdalet. And one more thing is retrosternal hernia. And the other name for retrosternal hernia is Morgagni hernia, because it opens through the foramen of Morgagni, which is situated between the xiphoid process and costal margins of the diaphragm. I'll show you the image. Don't worry. The other name for the foramen of Morgagni is space of Larry. Okay, that's it. So we have congenital and traumatic. More important are retrosternal and posterolateral. This is most common. We also have other two, which is central hernia and most posterior hernia, which is very rare. Okay, and there is no hernial sac here. The posterior hernia means it's just failure of the development of the posterior part of the diaphragm, in which there might be an absence of right or left crus. That's it. And because of the absence of the crus, the aorta and esophagus, they lie in the gap. But as such, there is no hernial sac here, posterior hernia. Central hernia is very rare, and it is present more or less in the central tendon part. Okay, and it develops due to the rupture of the fetal membranous diaphragm. Okay, so that's it. So we have a retrosternal hernia, we have a posterolateral hernia, we have a central hernia, and we have a posterior hernia. When it comes to acquired causes, we have both traumatic and the hiatal hernia part. Let's see them through the help of an image. As I already told you, we have a central hernia which is rare, which is presenting in the central tendon, but more common is posterolateral one, and it is more common on the left side. You can see the posterolateral hernia, and we call this as foramen of Bojdalet. Okay, and next important thing is anterior foramen of Morgagni between the xiphic sternum part and the xiphoid process here, and this is more or less on the right side. Okay, so Morgagni hernia is more on the right side, the Bojdalet hernia is more on the left side, and we have a central and we have a rare posterior. So these are congenital hernias. When I talk about traumatic hernias, bullet injury might cause a gap in the diaphragm leading to herniation. That is one. The other one is hiatal hernia. Hiatal hernia is divided into two types again. One is congenital hernia, and the other is acquired hernia. Though hiatal hernia we are reading in the acquired part, there is a congenital counterpart to it. Okay, so this congenital hiatal hernia is due to persistence of embryonic peritoneal process in the posterior mediastinum. So where it is in the posterior mediastinal part, there is a persistence of the embryonic peritoneal process which take parts in the process of diaphragmatic formation. So because of this, the stomach can roll upwards and it can lie in the posterior mediastinum. So the stomach is rolling up. So that's the reason we also call it congenital hiatus hernia as rolling type of hiatus hernia, or we also call it as paraesophageal because it lies to the side of the esophagus. So we call it as a paraesophageal hiatus hernia. And what happens because of this? The normal relation of the cardioesophageal junction, as you can see, the normal relation of cardioesophageal junction and the diaphragm is not disturbed. So therefore, the patient will not complain of GERD or gastroesophageal reflux disease. But that is more common with acquired hiatal hernia. What happens in acquired hiatal hernia? We also call it as the sliding type of hernia, which is the commonest type of all internal hernias, and it is due to weakness of the phrenicoesophageal membrane. See this membrane, phrenicoesophageal membrane, which holds the esophagogastric junction tight. So because of its weakness, it slides up, and this will disturb the gastroesophageal junction mechanics, leading to GERD. So symptomatically, the patient presents more with sliding kind of hiatal hernia rather than rolling, because this is due to the congenital weakness in the peritoneal persistence of the peritoneal process in the posterior mediastinum, and we call it as a paraesophageal. But this is due to acquired weakness. This leads to migration of the esophagogastric junction, leading to development of the GERD symptoms. So this will conclude our discussion on diaphragm. So we tried to cover both the parts of the in thoracoabdominal diaphragm and also the pelvic diaphragm. So let us quickly look at the questions asked from these topics. So of late, it's 10 years back they asked questions on it. They might repeat them. One is write a short note on pelvic diaphragm. You have to write the two muscles, levator ani and coccygeus, which are forming a part of it. And next is describe pelvic diaphragm. Write in brief about its applied anatomy. You have to write about the prolapse of the uterus or prolapse of the rectum, and add a note on supports. We will be discussing the supports when we deal with the uterus part. And the next question is describe the gross anatomy of thoracoabdominal. You have to write the openings. You have to write about the central tendon and also what is the crus of the diaphragm and all, and mention the structures. So draw a table mentioning the T8, T10, T12 segments. Okay, so that's it. This will conclude our discussion on the diaphragm part. So from abdomen and pelvis, the clinical aspects are clinical anatomy of the inguinal canal, and its boundaries and contents are important. So we'll be discussing the boundaries of inguinal canal, what are the openings, and what is the importance of Hazelback's triangle, and the applied anatomy aspects. We'll try to differentiate inguinal hernias from direct and indirect inguinal hernia. And at the end, I'll be also detailing you about this important stuff called the triangle of doom, the triangle of pain, and corona martis, which are actually important anatomical aspects during the laparoscopic repair of an inguinal hernia. So of late we are doing laparoscopic surgeries for inguinal hernia. Okay, so we have TEP and TAP. Okay, transabdominal and intraperitoneal operations, and for that the laparoscopic surgeon should be aware of these anatomical aspects. So this might be a potential question in the upcoming exam, so we'll be focusing on that. So let us quickly go back to the boundaries of the inguinal canal. So what is an inguinal canal? Inguinal canal is a 4 centimeter long. It's a 4 centimeter long intermuscular canal. So that means its boundaries are made up of the abdominal wall muscles. So it's an intermuscular canal. It's a 4 centimeter long canal, and it travels downwards, forwards, and medially like this. Okay, to the pubic tubercle, and we have anterior superior iliac span. From there it travels anterior, forward, and downwards. And what is its important function? It is a gateway, and it allows important structures like spermatic cord, okay, to pass from the abdomen to the testis. So it's a gateway, and also in females it permits the passage of round ligament of uterus. So I'll be teaching you the contents and all, but it's a passage, it's an intermuscular canal, and it's a 4 centimeter long canal. And you can see it in the image. See this? It starts from deep inguinal ring, and it opens into the superficial ring, and it carries the structures like this. So this is the inguinal canal. And let us look at the boundaries of the inguinal canal. As it's an intermuscular canal, it has 4 boundaries. Remember, anterior and posterior, superior and inferior. So we have 4 walls. Let's take anterior wall first. Anteriorly, yes, you can see the skin followed by the superficial fascia. We have it, both of these. And beneath that, we have external oblique aponeurosis. External oblique aponeurosis. Try to remember this. You have to memorize this. So what is the anterior wall? Skin, superficial fascia, and external oblique aponeurosis. This external oblique aponeurosis is a wall throughout the length, and beneath that we also have internal oblique aponeurosis, okay, or internal oblique muscle fibers, and they are present only in the lateral 1/3. So this part, if it is starting from deep and it is progressing to superficial, and in only lateral 1/3 you have an internal oblique muscle fibers or aponeurosis. So this anterior wall is the strongest wall of the inguinal canal, and it is made up of skin, superficial fascia, external oblique aponeurosis, and internal oblique muscle fibers only on lateral 1/3. Let's quickly jump to the posterior, which is the weakest wall. Okay, and posterior wall is formed of important structure is fascia transversalis. So what is that posterior wall? It's made up of fascia transversalis. Along with that, yes, there is a kind of extra peritoneal connective tissue will be there, and also along with the extra peritoneal connective tissue, the posterior wall is formed by the peritoneum. But for you, the take home is fascia transversalis is the posterior wall. Anterior wall and posterior wall are done. Let's now look at the superior wall. Yes, there are some more structures, in the posterior wall. We also have a conjoint tendon in posteriorly. So the posterior structure also has conjoint tendon. It's a kind of a reflected part of inguinal ligament. Okay. So this conjoint tendon is present more on medial 2/3 of inguinal ligament. So that's the reason the medial 2/3 is strongest on the posterior wall, the lateral 1/3 is the weakest. And when it comes to anteriorly, the lateral 1/3 is strongest and medial 2/3 is weak because it has a superficial inguinal ring. Okay, so this is anterior and posterior wall. Let's look at the superior and inferior walls now. You take superior wall. Superior wall is made up of two muscles, internal oblique muscle and the other muscle is transverse abdominis muscle. Okay, so these are the two walls of which superior wall, two muscles of which superior wall is made up of. When it comes to inferior wall is formed by fusion of the transverse fascia transversalis or transversalis fascia, which is also a posterior. So from posterior it comes down inferiorly and it fuses with two important ligaments. Okay, one is inguinal ligament and the second ligament is lacunar ligament. So these are the two ligaments with which the fascia transversalis fuses and it forms inferior wall. So these are the boundaries of the inguinal canal. Let me revise it again. Anterior skin, superficial fascia, external oblique aponeurosis and internal oblique muscle fibers only in the lateral 1/3. Posterior wall is fascia transversalis, extraperitoneal connective tissue, peritoneum, and also the conjoint tendon, which is more on the medial 2/3 of the inguinal canal on the posterior side. Superior wall is internal oblique and transverse abdominis muscles. Inferior wall is fascia transversalis with two ligaments, inguinal ligament and lacunar ligament. So this will conclude the boundaries. Next is the openings associated with inguinal canal. We have two openings. As I already told you, it's an intermuscular canal. It allows the spermatic cord to pass through, and we have a deep inguinal ring and superficial inguinal ring. Okay, so this deep inguinal ring is also known as internal inguinal ring because sometimes they confuse you, and the superficial inguinal ring is known as external inguinal ring. Okay, it's an external and it's an internal opening. Let's go back to the internal part. The deep or internal inguinal ring, it's an oval defect. It's an oval defect and it's an opening in fascia transversalis. What is fascia transversalis? It forms the posterior part of the inguinal canal, right? And the entry, it is an entry point for spermatic cord in males and round ligament in females. And where it is located? It is situated about ½ inch at, so this is the inguinal ligament what we have. So ½ inch above the inguinal ligament from, what is that? Very important, mid-inguinal point. And it is, these are inferior epigastric vessels, very important. This is inferior epigastric vessels, and this deep inguinal ring is located lateral to the inferior epigastric vessels. So let me put it this way: an oval opening in the fascia transversalis is deep inguinal ring, which contains spermatic cord in males and round ligament of uterus in females. And where it is located? It is located ½ inch above the inguinal ligament from the mid-inguinal point, and it is lateral to the inferior epigastric arteries. So this is all you need to know about the deep inguinal ring, also known as internal inguinal ring. Let us look at the superficial or external inguinal ring, where it is located. It's a triangular opening, not oval, it's a triangular opening, and it is located in aponeurosis of, where it is located? It is located in aponeurosis of external oblique muscle. So external oblique muscles, aponeurosis, it forms anterior part, anterior wall. Okay. And where does it lie? It lies just immediately above the pubic tubercle. Okay, immediately above the pubic. This is the pubic tubercle we have, and it lies lateral to it. So it lies immediately above and lateral to the pubic tubercle, but medial to the inferior epigastric vessels. So this is all you need to know about the external ring, because external superficial inguinal ring is triangular in shape. Okay, there are some boundaries for it. Apex is a bit superior and lateral, as you can see, and the base is inferior. Base is mainly formed by the pubic crest, but the lateral and we have both medial wall and lateral wall, which are attached to the pubic symphysis and pubic tubercle respectively. We have medial and lateral wall, and medial wall is attached to the pubic symphysis and lateral wall is attached to the pubic tubercle. So this is pubic tubercle, and we have pubic crest here. So that's it. This is the openings of inguinal canal. So let us look at the contents of this inguinal canal. After that, we'll go to the Hasselbalch's triangle. So I'll write the contents here only. So instead of openings, I'm writing down the contents here. Make a note of this contents of inguinal canal. So inguinal canal contains, as I told you, the spermatic cord in males, and very important, round ligament in females. And in both the sexes, we have the genital branch of genitofemoral nerve. This is one nerve which is present in both the sexes, and the second important structure is ilioinguinal nerve. So what are the contents of spermatic cord and round ligament? It's beyond the scope of our discussion, but at least remember these are the contents. So if they ask you to write down the anatomy of the inguinal canal, you know the boundaries, openings and contents. Also, don't forget to add a note on Hasselbalch's triangle. What is this Hasselbalch's triangle and why it is important? So through this Hasselbalch's triangle, the inguinal hernia, that is an indirect inguinal hernia, which is commonly seen in older individuals, it comes out of these Hasselbalch's triangle, because it is present in the posterior wall and it is a bit weak. Okay, and let's see the borders or boundaries of this Hasselbalch triangle. So we have mistaken here. This is not like Hasselbalch's triangle is not the weak area. Okay, Hasselbalch's triangle is present medially, and lateral to the Hasselbalch's triangle you will see indirect inguinal hernia. Okay, so both are different. Let's look at only the Hasselbalch's triangle first. The Hasselbalch's triangle has a medial border, and you can clearly see what it is made up of. It is made up of rectus abdominis muscle. See this? This is the rectus abdominis muscle, is the medial border. So it's a lateral border of rectus abdominis muscle is the medial border. And what is the lateral border then? Laterally it has, we have inferior epigastric artery. So this is the inferior epigastric artery. And on the base we have inguinal ligament. So as I already told you, this is the inguinal ligament extending from anterior superior iliac spine to the pubic crest or pubic tubercle. So this is the boundaries for Hasselbalch's triangle. Now let's see the applied anatomy aspects. We have two things here. One is first thing is, I'll tell you the definition. What is inguinal hernia? It's an abnormal protrusion of abdominal contents. Okay, maybe omentum or intestine. So it's an abnormal protrusion of abdominal contents. And this part of the inguinal region, like this applied anatomy of the inguinal canal, the protrusion can contain the greater omentum or intestine, and it has two types. One is a direct hernia and other is indirect hernia. Let me tell you, the most common type is always indirect hernia in 85% of the people. It is seen in children and young adults, and it's the most common variety. Anatomy aspects we will see with the image, with the help of an image, but more important thing is when it comes to direct hernia, it is seen in older age people. Okay, and it comes through the Hasselbalch's triangle. As I already told you, it's a protrusion. It lies medial to the inferior epigastric vessels, and this Hasselbalch's triangle is a weak area. But more important thing is, there are some etiological factors for this development of direct hernia. Because the posterior wall is weak, what happens from the Hasselbalch's triangle, because of either chronic cough or lifting of heavy weights or abdominal wall weakness or malnutrition, any condition, intra-abdominal tumor leading to a raised intra-abdominal pressure, all these conditions leads to the direct hernia part. So let's see the anatomical differences between these two. So these abnormal protrusions, as I told you, are of two types, direct and indirect. The direct inguinal hernia, the deep inguinal hernia, enters through the weak posterior wall medial to the inferior epigastric vessels, that is from the Hasselbalch's triangle. It is how it protrudes inwards. Okay, through the weakened posterior wall. So the bulge is medial to the inferior epigastric vessels. Please remember this. But an indirect inguinal hernia, it protrudes through the deep inguinal ring, and this is a bit lateral. As you can see, it's lateral to the so let me put it this way. So we have two things here. One is direct inguinal hernia and the other is indirect inguinal hernia, and the structures what we are seeing is the parietal peritoneum, the conjoint tendon, the peritoneal bulge, we have superficial inguinal ring, and we have testicle here, and you can see this, there is no sac here, but there is a sac for this, and it is entering into the deep inguinal ring. And one classic difference between a direct versus inguinal hernia is direct, a bulge is medial, whereas indirect, the bulge is through the deep inguinal ring and it lies lateral to the inferior epigastric vessels. So this is medial and this is lateral structure. So this is the classic difference between direct and indirect inguinal hernia. So we're done with the inguinal hernia part. Let us now focus on the applied anatomy aspects of laparoscopic one. So focus here, this is the view from a laparoscope. You have three important structures. One is triangle of doom, the other is triangle of pain, and other is corona mortis. Okay, the surgical dissection and application of any stapling is avoided in triangle of doom because it injures the external iliac vessels. So what are the contents of triangle of doom? The external iliac vein and the external iliac artery. These two important structures. If you put a staple or any suture here, that might damage the iliac vessels leading to the death. So that's the reason it's triangle of doom. So what are the boundaries here? The same thing here is the triangle of doom. The boundaries of the triangle of doom are laterally, they are made up of gonadal vessels. So this is lateral. And medially, medial is the vas deferens. See, this yellow colored structure is vas deferens. So the boundaries laterally are gonadal vessels, medially is the vas deferens, and the base is formed by the peritoneal reflection. See the peritoneum getting reflected here. So the base is, and we have an apex which is present at the deep inguinal ring. Apex is at the deep inguinal ring, and the contents are external iliac artery and veins. This is very important, the boundaries and the contents. Similarly, we have another triangle called triangle of pain. You can see just medial to the triangle of doom. So lateral. It lies lateral to the triangle of doom, and because why it is triangle of pain? It contains so many nerves. So if there is any suturing or stapling here, there will be nerve entrapment and there will be painful neuralgias. So what are the contents? So when I say it is rich of nerves, it contains very important femoral nerve, and it also contains femoral branch of genitofemoral nerve. Okay, and also lateral femoral cutaneous nerve. So these are the three important nerves which the triangle of pain contains. So what are the boundaries again? It has a lateral, you will see here, it has a base and two walls or two boundaries. Laterally it is made up of iliopubic tract, and medially it contains the gonadal vessels. See, this is the medial one and it's the lateral one, and laterally it is made up of the iliopubic tract. There is third important structure. If you want to remember, it's well and good, or else you can forget it. There is a structure called corona mortis or circle of death. Okay, because there is a circle of vascular rings here. So any damage to this during surgery, okay, so here it is present medial to the triangle of doom, which is a corona mortis, and lateral to the pubic tubercle. And this corona mortis contains a circle of vessels, and this arterial network is formed of these things. Iliac artery, we have both external and internal iliac artery along with the common iliac artery, and it also contains obturator artery and also inferior epigastric artery, and sometimes there will be an aberrant obturator artery. May not be important, but please remember the corona mortis is a circle of arteries, and any damage causes life-threatening bleeding, and you should be careful not to apply any staples here. So this is the applied anatomy of the inguinal region when it comes to both the laparoscopic surgery and also the differentiating inguinal hernias. So we are done with the inguinal region, its anatomy, and also the applied anatomy in detail.